Yeah, thank you very much for this nice introduction. And also, I want to express my gratitude to have the opportunity here to present our, well, the way how we treat patients, maybe also our kind of medical philosophy. And it's very interesting to, well, to share this data and also our conviction that we think that at the heart of treating patients nowadays is also giving them back purpose, especially the patients I'm going to talk about. And as you see here, Il faut cultiver son jardin is one of the most famous last sentences of the literature of the Age of Enlightenment. So Voltaire ended his novel Candide by letting the hero of his novel Candide say, well, maybe after he has endured any catastrophe you can invent, and he had been fed by philosophical speeches from his philosophical teacher Pangloss, but in the end he said, you know, why don't we just cultivate our garden? Why don't we just give our life some kind of meaning, some kind of purpose, and coming back to the real life to get pragmatic, if you're allowed to say so. So this is the metaphor of our talk. Cultivating one's garden is giving back purpose to our patients. And the patients we have, of course, are the ones who really need another way how to how to do their life and to give them back some kind of responsibility. That is the important part, because the problem in clinic is, as you see, that out of many issues like safety concerns, like we also want to protect our patients, and we strip them out of their responsibility the more they get into the disease of neurodegenerative diseases like Alzheimer's, for example, or even Parkinson's dementia, and so on. So that is our main goal, to give them back somehow a thing that they can feel responsible for. Because as you say here, this is we call it a triangle of sadness, if you say so. It's the patient who has got his basic needs, and he's somehow in this triangle with a caregiver who wants, of course, to offer his help, but also you have the environment which is either overstimulating or understimulating. And out of all these conflicts, there are the concerns which somehow restrain us in our therapy. So we have, of course, medication and stuff, but what we don't have is the opportunity to give these patients somehow their life back, or at least a new thing which they can fulfill during their day, during their, well, let's say in the hospitals most of the times, and also in nursing homes, it's a period of agony. And so we want to get out of this agony by doing something very special with them. And the problem is, let's look at the evidence. What is the current situation? When you look at it, pharmacology, there's been a huge meta-analysis published recently, giving information about which kind of medical remedy would help. So as you can see here, it's really very low, and that's the problem. I mean, we can somehow get the patient in a state that he's not so much agitated, but what does that mean in terms of quality of life for the patient? So, and even the medication, the regular medication we give in demented patients, it doesn't reach the level where it has to be. It was shown that it really improves the quality of life of the patient. So we thought maybe let's turn back and look at another thing. And that is what we see now as we see here, the gold standard. It's cognitive behavioral group therapy. So in this group therapy, as you can see here by this also pooled data put together different studies who analyzed this group therapy things we did here, and it showed that also, this is more evidence than the medication we actually give. So that's the point, and we thought, okay, so let's look at this more. So what does that mean in terms of cognitive group therapy, and what does that mean for how we can get these ideas back into the patient? So we need to improve what we call in the clinic the activities of daily living. And of course, we need to occupy the patient. So occupational therapy, it makes no really wonder that these therapies rank among the most best rated in these studies. And then, of course, it should be person-centered, all the kind of therapy. So according to what we think, it makes not so much sense to just put them in front of some screen or even give them some VR lenses and say, okay, let's somehow try to emulate a situation. No, they have to get really back into a real life situation which they can connect with experiences they have endured during their life. So being active, that's the core of our efforts, and having a role. So what kind of role should we give the patients? And then we think role is such a high word. Yeah. So when you are in a demented state, you feel even responsible for a flower in a pot. Or you have a high bed, for example, and you start caring for something. So this is not only giving a patient purpose, but also giving him responsibility. And that's the really very important part. And I was intrigued by reading the book I can recommend you from Robert Polk Harris and Gardens. It's about the human condition and gardening. And it really gives the garden a kind of symbol, as a kind of sanctuary for humanity, so that people really come back to their natural sources, and they come back and they calm down, of course, and they come back to do something which they relate also in their biography. Of course, everybody has got a biography with encounters in nature. And so this is also something which gives them back a good feeling, which gives them back some kind of good memories from their youth and younger ages. Because what is known in clinical terms is that during the process of dementia, they have kind of retrograde memory. So that means they lose more memory the earlier it comes from. So the latest memory they get, they lose earliest. So the things they experience during childhood, for example, this is something which really sticks. And so that's the age when they tried to walk through forests, they had maybe gardens, and they worked there with their parents. And that comes back, that's a theory, when they do some kind of gardening work. And of course, as I said, it's a personal centered care. So it's really recognizing the individual as it is. It's not a number, it's a whole biography which you see and which you try to treat. And that gives also back a very good sense in the clinical team, in the nursing team, for example, because they don't see this as an old person which we have to somehow feed during their stay in the hospital, or we have to calm it, or we have to do something which we don't know how it relates to their biography. No, it's something which they can work with these patients. They can exchange experiences by showing, for example, leaves or flowers, or even pieces from the garden. And so they come back into a kind of dialogue. Of course, we all know that most of them are lacking more words once the development of the dementia starts. But still, it's a very person-centered approach and very individual to each patient what we do. And of course, as we say, the resources are somehow fostered in these patients. So they know, and that was one of our experiences once we started our study, that when the therapist is coming, that they are doing something with them in the garden. So they're even standing there, and they say, oh, today are we going out into the therapy garden? So that gives them also a structure. So this is also important during this process of agony, let's say, that you have a structured daily, hourly thing that you can do and in a regular manner. That's the important thing. So we think that this approach and doing the garden space, and these are some pictures we have experienced in a therapy garden we invented from the University of Essen-Duisburg. So we have a designed garden together with a faculty of landscape architecture. And we had a huge area back there. It was in Ratingen. There's a village for elderly people in particular. And they asked us from the psychiatric clinic in Essen to help them out, to give them somehow advice how to treat the patients. And we said, oh, this is a very interesting idea. Why don't we jump in and do a study together? The problem with this was, it was a nice idea, but we didn't have any control. So to prove that a concept really works scientifically, of course, we have to get an RCT. And that's the problem, because without any control and without randomization, we cannot really prove scientifically that this is a good concept. So, and when I came back to Munich now 9 years ago, I thought, okay, I'm never want to go back into this trap again without a control group. And I was very grateful to a foundation, and they gave us 250,000 euros to build 2 gardens in my hospital in Haar, and but 2,500 is just enough to rebuild 2 gardens in a hospital setting. So the other 2 gardens we had were not rebuilt. So that was our trick to get the control group, and no ethical constraints, of course. And the randomization took place because the patients were assigned by a central authority. So we had no influence on which patient came onto what specific ward. So, and based also on the data from Moroni and Wong, we saw that these therapeutic gardens in general, they improve, of course, the quality of life of our patients, and they are better on depressive symptoms, anxiety, and the number of thoughts, and of course, they reduce the overall medication in our patients. So this is what we have designed for the therapeutic garden outside here Munich in Haar. And the thing is, you can imagine, so we had big problems with the other 2 gardens which we didn't rebuild, because the nurses wanted to do something for their patients, and they were sitting together to get some action. And I said, oh no, we were losing our control group. So I had to tell them, you know, next year when this study, of course, is done, we can start with rebuilding also the other gardens. But this is the purpose. So translate our garden into some designed field where you can do kind of occupational group therapy with these patients, which otherwise would stick in everyday's agony. And that's where will be the problem. So, and what we also had, that it was very good for the nursing staff and also for other staff, that they were involved into something which really gave them more sense to their daily work than they experienced previously. So also in terms of the people who work in the hospital, it gave a good amelioration of their job situation or of their professional identification with what they were really doing. So it was really a good thing. So closing with Candide, whom I started, you know, the full title of the novel Candide is Candide ou l'optimisme. So the optimism is also proven so far scientifically, because there was a recent study by Stenlund from the American Journal of Geriatrics, just recently published, and it showed that people who have a certain level of optimism during their senescence, they really have a lower dementia risk, as I said here. So 1 standard deviation of optimism is like a 15%, they did the maths on that, lowers the risk of dementia. And that is really, I think, a very, very good quote to really end. And so I hope that we get our results published very soon. And so let us all, as it said here, let us all cultivate the garden. There's ours. And of course, keep our own optimism as an asset for prevention alive. So thank you very much for your attention and giving me this opportunity, sharing our basic principle, how we treat our patients. Thank you very much.